Welcome to Complexity in the Cognitive Work of Nursing, Implications for Nurse Educators. This module is presented in three parts. The first part focuses on defining the three primary factors of cognition that determine how people arrive at intentions to act, or what informs decisions made by nurses for care delivery. The second part will describe findings from research about specific patterns for each of these factors in data collected from RNs about their actual work experiences. And part 3 defines and describes RN stacking, a cognitive process of tracking, organizing, and prioritizing care delivery activities with implications for safety and quality. Following completion of this module, participants will be able to explain the cognitive work of RNs during actual care delivery, examine the concept of stacking and its importance in managing work complexity, and explore teaching strategies that introduce students to workflow management decision-making before graduation. Complexity in the cognitive work of nursing, implications for nurse educators. Part 1. Three primary factors of cognitive work that inform worker decision-making in complex environments. As introduced in the module Appreciating the Complexity of Nursing Work, Implications for Education, a major barrier to making progress in safety and quality is the failure to appreciate the complexity of nurses' actual work in real care delivery situations. In that module, we introduced you to the work at the sharp end of practice framework to guide our understanding about the important aspects of real work in complex environments that are characterized by the demands and challenges like those faced by RNs in our current healthcare systems. This module focuses on the sharp end triangle, or the direct provider role of the framework. The inside of the triangle represents three important aspects involved in cognitive work that include knowledge, mindset, and goals. It is the coordination of these aspects that results in specific decisions regarding care delivery during actual work situations. Three major types of cognitive factors surround intentions to act and inform decision-making in complex or challenging environments like healthcare. These include factors related to the activation of knowledge, the attentional dynamics governing mindset or flow of attention, and the strategic factors leading to interactions among multiple goals. Let's talk about each of these three sets of factors and think about how these might influence our teaching or design of teaching strategies. The first type of cognitive factors leading to intentions to act or decisions are activation of knowledge factors, or those related to the knowledge that can be used to solve problems in context. The next slide describes three activation of knowledge factors. Activation of knowledge factors include the knowledge content available from basic education, continuing education, and experience that can be drawn upon for solving problems or reaching decisions. This includes the textbook description of specific patient medical and nursing diagnoses, as well as the patient response patterns observed by nurses after multiple encounters with similar patients. We know that knowledge content is necessary for appropriate decision-making, and re-education and reinforcement of content continues to be the most often used strategy for students and RN education after near-miss or adverse events. Knowledge content, however, is not sufficient for safe practice. Knowledge organization is the mental model or collection of knowledge used to inform a specific action or decision to act. The knowledge organization in a situation for a care provider may be accurate or inaccurate, complete or incomplete, depending on the situation. If knowledge used to inform the mental model of the situation is inaccurate or incomplete, the mental model is termed buggy, a term used in human factors literature to depict mental models giving rise to inappropriate actions. New or unusual situations may be particularly prone to formation of buggy mental models, where knowledge content is available, but the novel situation calls for a mental model that reflects the relationship between knowledge content factors, a relationship not examined by the nurse or student previously. How do we, or might we as educators, develop teaching strategies that force student examination of relationships between relevant knowledge content for application in new situations? Knowledge activation is the third knowledge factor important for decision making or intentions to act. A person may have the knowledge to solve a problem, but not activate it in relevant context where it may be useful. For example, a student may have learned about relationships between lab values, urine outputs, and volume in the classroom, but may not activate this knowledge in the actual context of care delivery and decisions for a specific patient care assignment. The student may not be able to apply the knowledge in the actual patient care context, or the knowledge remains inert in the situation. Some knowledge activation depends on the care provider recognizing subtle patterns of information that are not readily available in every case. Therefore, the care provider may know the information, but not call upon it, or have time to recognize patterns quickly enough to activate it in the new situation. We in nursing education have historically focused exclusively on knowledge content, inadvertently assuming that there is a direct and corresponding relationship between students' acquisition of this knowledge and their ability to apply it in practice. Considering all three knowledge factors as we strive to embed QSEN competencies in our courses and curricula will provide students with more robust skills for use in practice than merely large stores of knowledge content. The second major cognitive factor important for intentions to act and decision-making in complex environments is attentional dynamics, or those factors that affect mindset or flow of attention. Complex work environments are very dynamic, often with unpredictabilities surrounding patient clinical conditions, patient scheduling and movement, and the performance competency and availability of other resources. For accurate decision-making and appropriate actions, RNs must be able to maintain situation awareness, or in other words, be able to track new information and cues and the patterns of interactions among the information and cues evolving over time. First, maintaining situation awareness requires the RN to be mindful, to pay attention to what is going on around them, or to be in a state of mindfulness about their flow of attention surrounding the work. Mindfulness has been referred to as the struggle for alertness, or as the ability to see the significance of early and weak signals and to take strong, decisive action to prevent harm. Second, situation awareness requires the RN to be able to make sense of the current and updated view of the system by taking time to make sense out of new and changing circumstances, or sense-making. We are learning from complexity science principles that in complex adaptive systems, for example, a patient in an individual clinical unit or in a healthcare clinic, we have learned that trouble starts small and is signaled by weak symptoms that are easy to miss, and also that small discrepancies can accumulate, enlarge, and have disproportionately large consequences. These systems require mindful practitioners with capacity for accurate sense-making about what is going on. You can refer to the module entitled A Taste of Mindfulness to learn more about helping students learn to be mindful. The third major cognitive activity important for intentions to act and decision-making in complex environments is the cognitive activity involved in consideration of strategic factors, or the management of conflicting goals. Due to the dynamic nature of healthcare systems as complex work environments, achievement of goals often requires completing activities relative to one goal at the expense of another. For example, an RN chooses to have a patient requesting a pain medication wait another few minutes to be able to check on another patient with unclear and subtle changes that might be indicative of a deteriorating condition. Examples of competing goals are clearly evident in the daily practice of RNs in any healthcare system, especially when consideration is given to the multiple safety, quality, and satisfaction guidelines, policies, and procedures that are currently in place. As you can imagine, problem solving for RNs is not limited to the best decision making about patient clinical conditions and clinical responses. Problem solving for RNs includes intentions to act and decisions about what to do next or when in relation to competing goals for patient care, which includes decisions about how to achieve multiple goals given the uncertainty, risk, and pressure of limited resources. How well are our students prepared to practice in uncertain and time-pressured situations? How might we better help students begin to develop their abilities to deal with these strategic factors? We'll now go on to Complexity in the Cognitive Work of Nursing, Implications for Nurse Educators, Part 2, Cognition Factor Patterns Found in the Actual Practice of RN Work. Findings from research examining RN work in multiple settings using the work at the sharp end of practice framework reflected several patterns in the coordination of knowledge, mindset, or attentional dynamics, and goals, or the strategic factors, that inform their work leading to decisions about care delivery. And interviews with RNs about actual thinking during the work of care delivery revealed the impact of multiple interruptions, distractions, and cognitive shifts, and the challenge of maintaining focus and sense-making in the midst of actual care situations. In addition to 3 general patterns of knowledge content, several desired overall goals or strategic factors were identified. The cognitive work of RNs demonstrated that problem solving about what to do when and how included not only the knowledge content represented, but also the ability of RNs to deal with how to meet 2 or more of these sometimes conflicting goals. In addition, a cognitive process called stacking was revealed that represents a workflow management process, which is discussed in Part 3 of this module. For more about how to help students become more mindful, please visit the module entitled A Taste of Mindfulness. Activation of knowledge was the first major cognitive factor that informed intentions to act or decision-making and introduced in Part 1 of this module. Necessary for activation of knowledge was knowledge content, and 3 patterns of knowledge content have been found through research to include knowing individual patient information, knowing typical patient profiles, and knowing unit routines and workflow. For example, knowing about individual patient information might include that the nurse learns the patient is blind and needs assistance with taking medications. Knowing about typical patient profiles would include knowing what might present in a patient with a myocardial infarction. And knowing unit routines and workflow might be something like knowing that physician rounds are usually completed by 10 a.m., or that John the RN is great to work with. Knowledge content patterns included knowing about individual patient information. For example, the patient is blind and needs assistance with taking medications. One RN was observed to leave a patient who was on the floor after having fallen. After the RN's initial response to the alert that the patient had fallen, she checked the patient for injury and stability and then directed the nursing tech to stay with the patient until she, the RN, had returned. In the follow-up interview regarding her decision to leave the patient on the floor while she returned to another patient, she described her thinking that led to this action. She stated that she was in the middle of administering medications to a frail, slightly confused male patient who could not see very well and had very labile blood pressure readings the day before when she had cared for him. Once she had determined that the patient on the floor was not injured and stable and had a nursing tech at her side who could stay with her, the RN returned to the male patient to finish meds since she had left the medicine cup on the patient's bedside table. From her knowledge about this patient that she had learned from the day before, she could not trust that the patient would not try to finish the meds on his own, might lose the medication in the bed and be unable to locate them due to poor sight, which may then mean she would not know for sure if the patient had taken the important antihypertensive medication. This important individual and unique knowledge about a patient learned from caring for him the previous day informed the RN's decision-making on decisions about care for the patient who had fallen. Knowledge content patterns included knowing about typical patient profiles, for example, the patient with myocardial infarction. An RN on a general surgical unit was observed to immediately interrupt routine AM care for a set of patients after one younger patient started complaining of new onset chest pain. The patient's description of the pain was similar to her recall of the typical complaints of patients with possible myocardial infarction. She notified a physician, called for a stat EKG, directed the nursing tech to take vital signs more frequently, and increased her direct monitoring of this patient. The patient's symptoms slowly subsided, and the RN decreased monitoring after a visit and check by a physician and no indication of EKG changes. The RN's decisions about what to do with this patient's complaint were based on her knowledge of what she had learned about the typical picture of patients experiencing an MI. Interestingly, the RN also revealed during the interview that she was focused on this patient not only by her knowledge of patients with an MI, but also by her knowledge of specific individual patient knowledge regarding this particular patient whom she knew. The patient had had a cardiac arrest early on in her current admission to the hospital. Both sets of knowledge informed this RN's subsequent decision-making about this young patient and the likelihood of a cardiac event. This experienced RN was able to organize, activate both aspects of her content knowledge, resulting in a mental model that she used to guide her care in this unique situation. In what ways and how often do we expose our students to novel care situations that require recognition of the relationships between knowledge content areas of individual patient information and typical patient profiles? Knowledge content patterns included knowing unit routines and workflow. For example, physician rounds are usually completed by 10 a.m. or John the RN is great to work with. Interviews of RNs revealed repeated references to knowledge content about the how and when of unit-related routines and abilities and competencies of those with whom they worked. One RN related that she never returned to the nursing station before 10 a.m. or when the medical staff had usually finished with rounds, unless there was a new stat order. She had found that returning before that normally interrupted her routine for AM care and caused distractions. She also delayed taking off orders until after that time to make checking orders more efficient. As a testament to her knowledge of and appreciation for the unit routine workflow patterns, she remarked also that if she did not have a certain amount of work completed by 10 a.m., she knew that the rest of her day was shot. Other RNs talked about anticipating how they knew their day would go based on knowledge of who was working the same shift when they arrived, and they would make decisions about care delivery and order of work based on this knowledge. What became very clear in understanding the work of RNs in actual care situations in complex healthcare settings was that RNs used more than knowledge about typical patient disease profiles and more than the individual and unique patient characteristics and preferences. RNs include knowledge of the work environment routines, the norms, and resource availability and competencies in combination with other knowledge content to inform their decision-making about clinical care. In what ways can we introduce this complexity to our students to begin the more complicated decision-making needed for actual care delivery in real settings? Attentional dynamics is the second major type of cognitive factor informing intentions to act or decision-making and include issues that affect attention and cognitive workload as situations change and evolve. At any point in time, a sharp-end worker or care provider has a certain mindset that is dependent on the attentional dynamics that are operating at the time. Attentional dynamics include the processes referred to as situation awareness, or to tracking the shifting patterns of interactions in the system under control, for example, individual patient, assignment of patients, unit workflow, and others. Maintaining situation awareness requires shifts of attention. However, too much distraction, unpredictability, and ambiguity can lead to breakdowns and difficulty. Therefore, maintaining situation awareness requires the RN to be mindful, to pay attention to what is going on around them, or to be in a state of mindfulness about the flow of attention surrounding the work. Mindfulness has been referred to as the struggle for alertness, or as the ability to see the significance of early and weak signals and to take strong, decisive action to prevent harm. Second, situation awareness requires the RN to be able to make sense of the current and updated view of the system by taking time to make sense out of new and changing circumstances. The contribution of knowledge factors, or the content, organization, and activation, is dependent on the RN's capacity for mindfulness and sense-making, or their mindset in any given care delivery situation. What can we incorporate into our teaching that may provide the student with learning about attention to mindset? How awareness of mindfulness and sense-making relates to safety and quality. How to incorporate mindfulness into care delivery. The module on A Taste of Mindfulness provides more information about helping students and ourselves become more mindful. Strategic factors represent the third major type of cognitive factor informing intentions to act and decision-making, and include conflicts and resolution and trade-offs, or how people cope with trade-offs among different goals that conflict in the midst of uncertainty, risk, and the pressure of limited resources. This cognitive factor captures the problem-solving abilities of sharp-end workers or care providers. RN interview data about goals that were operating in specific care delivery situations revealed goal patterns across RNs that fell into 7 categories. These goal patterns were to maintain patient safety, prevent getting behind, avoid increasing complexity, appear competent and efficient to coworkers, maintain patient-family satisfaction, maintain patient flow, and get everything done. Maintain patient safety and patient-family satisfaction as part of the goals of RN seems very clear and consistent with what healthcare customers and administrators would desire. 4 of the other goals are related to organization and completion of work. For example, prevent getting behind, avoid increasing complexity, maintaining patient flow, and get everything done. And attainment of all the other goals will to some extent determine accomplishment of the last goal, appearing competent and efficient to coworkers. Nursing education has historically focused on teaching to the patient safety and patient family satisfaction goals. Student learning about organizing and finishing work occurs primarily after completion of their basic programs and during orientation and the first year of practice. What we now know is that each of these goals compete and often conflict with each other in the midst of complex healthcare environments. The clear decision about what intervention is best for the patient, or how best to provide an intervention, competes with workflow goals. And if these goal patterns were found to operate in experienced RNs, how much more strongly do they influence a student's and the beginning new graduate's ability to manage care delivery safely and with quality? The student and new graduate do not readily observe and see clearly how experienced RNs accomplish the cognitive work needed to resolving conflict and competing goals. Most experienced RNs manage these situations effortlessly. How might we provide experiences to introduce the student to decision-making with multiple goals in conflict, with time constraints and pressures surrounding the situation? We cannot possibly provide them with every potential situation that might arise. But can we provide situations that make them aware of the difficulties surrounding decision-making in light of conflicting goals, the need for trade-offs between competing goals, and when and how to get assistance for making the best decisions? We have documentation about the complexity of RN work environments through direct observation and asking RNs to talk about their work. We also know that there is cognitive work that is extremely critical and invisible to others, and yet very important for safe delivery and quality of care that is required due to the demands of the work environment. This 7-hour timeline represents one RN's work on a medical surgical unit surrounding medication administration. The hits along this timeline are either medication administration activities or activities that interrupted the medication administration process. While the timeline of activities for this one RN looks overwhelming in itself, it does not capture what we know is the essential component of RN work related to safety and quality, or the mindfulness and sense-making needed to make appropriate decisions about care delivery interventions and best organization of that care delivery over a shift. Part 3 of this module presents what we currently know about RN stacking, or the cognitive workflow management process RNs use to deliver care. In an attempt to understand more clearly the complexity of RN work in actual care situations, a cognitive process of workflow management emerged from observation and interview data found to be universal in experienced RN practice, and yet not uniformly addressed in nursing education. This process is called RN stacking. Additional focused study of this process has resulted in a beginning knowledge base from which nursing educators can begin to look at the work of RNs through a different lens, one that includes the primary types of cognitive factors that inform decision-making in complex situations and discussed in parts 1 and 2 of this module. Looking through this lens makes it clear why content knowledge, although necessary for students to become competent care providers, is not sufficient for successful practice in actual care settings. Through closer examination of RN stacking and in consideration of the essential aspects of cognitive work and effort demonstrated by RNs in the study, the following conclusions were reached. 1. RN stacking is a workload management strategy for dealing with multiple care delivery requirements. 2. RN stacking represents a list of multiple to-be-done tasks and the process of managing the list. 3. RN stacking is a failure-sensitive strategy for preventing error and or minimizing bad outcomes. And 4, RN stacking is a discriminator between novice and experienced RN practice. In addition, the effectiveness, or the breadth, depth, and efficiency of RN stacking appeared to be very dependent on the ability of the RN to maintain situation awareness, or the extent to which the RN could be mindful and make sense of clinical as well as workflow data throughout changing and dynamic situations. A more recent study investigating RN work documented 4 major themes related to this cognitive process. 1, a hierarchy of priority actions emerged that identified what activities would generally take precedent over others. Number 2, particular conditions tended to strongly influence RN's problem solving in difficult situations and decisions about stacking and managing the stack. 3, particular types of decisions were consistently made about what to do with the activities in the stack. And 4, novice RN and experienced RNs differed greatly in their ability to stack or manage the stack of care priorities. Identification of this hierarchy emerged from analysis across RN interviews, their direct observations, and focus groups. Work activities were coded by type and then analyzed for which type activities took priority over others in actual work situations, either observed or reported to be priorities in the flow of work by RNs. The hierarchy, therefore, is an overall representation of organization and prioritization by RNs in this study, and indicative of ordering during actual work situations. This hierarchy is not representative of the importance of any one of these activities over another outside the context of actual work, and provides some beginning understanding of the multiple factors included in decision-making by nurses in our current healthcare environments, beyond each patient's individual clinical status. The top priority category identified included imminent clinical concerns and high uncertainty activities. It was no surprise that if a patient was coding or bleeding out or having respiratory difficulty, RNs would respond immediately. They also prioritized very highly those situations where they were uncertain about what was happening. And these high uncertainty activities were not only related to patient clinical conditions, but also to unit or environmental situations whose outcome might have consequences for the flow of work, or impact the RN's ability to maintain control over the flow of events. Next on the priority list were those categories of activities normally considered the visible work of nursing: medications, dressing changes, assessments, and so on. But also in this level of the hierarchy were relationship management, or the resolving of conflict situations, or the recruiting of resources for future assistance. Experienced RNs learn that leaving a conflict situation between caregivers and families, or between individual caregivers, can affect their work all throughout the shift, and for that reason alone, they will prioritize that higher than other activities. The experienced RN also learns that identifying who is working that can serve as a resource later is worth recruiting through either social or direct formal requests for future assistance. Checking on and helping team members, documentation, patient education, and support all ranked below these other activities. Unexpectedly, pain management also was in the lower level of activities in the nurses studied. And yet it must be emphasized that the hierarchy represents what nurses revealed about activity priorities given the actual situations they were involved in and the demands inherent in those situations for managing the total picture of the work. The hierarchy does not represent what they would like to prioritize or think is the most important given unlimited resources and without time pressures. It represents their hierarchy given decisions about goal conflicts and the limited resources and unpredictability of the actual care situations they encounter. Activities prioritized lower in the hierarchy were system improvement activities, cleaning, error paperwork, and stocking supplies, each activity not usually a direct contributor to immediate and direct patient care flow. Personal breaks were found to be lowest on the hierarchy, although some nurses, and especially experienced ones, were found to include these fairly regularly. The second major set of findings were the multiple factors that RNs included in decisions made about prioritization, and that sometimes complicated problem solving about what to do next or what could wait. Factors related to timing were very important in decisions about how to order an activity. For example, these factors each reflected the importance of time. How urgent the need for action given the clinical situation, or the RN's perceived time constraints at the time of the prioritization, or the duration or length of time to complete the activity if started. The timing of one activity in relation to another, or does one activity have to occur before another? The actual or potential occurrence of unpredictable events influenced RN prioritization of activities. At times, everything had to be put on hold for some unpredictable situation, and a common goal of RNs in their workflow was found to be not get behind due to the unpredictability of what might occur later. This working to not get behind reflected another factor in prioritization, or the current level of control perceived during the actual workflow. Assigned load, or patient assignment, and workload influence decisions by its effect on ability to focus and attend to the changing environment. And perception of availability and effectiveness of team affected priority setting. Also identified as factors contributing to decisions made by the RNs in actual care was their level of experience in years of practice, and the constraints resulting from licensing and regulatory sources. Work-life factors that included psychosocial influences, such as peer and collegial relationships, and the ability to manage stress and cope with the work environment were important factors in decision-making, especially for the newer RN. New graduate RNs in the study on stacking, and those who were interviewed for a study on new graduate near-miss and adverse events, reported the focus on getting ready for a report that filled the last 2 hours of their shifts. The pressure to prepare a complete report or to complete all care was very strong and could be internally and or externally generated. Some near-miss and adverse events occurred during this later time during the shift when time pressures mounted, and the mindset of the new graduate was very narrow and often clouded by the goal of getting ready. Another work-life factor is the perceived availability of resources for help when work becomes hectic or questions need to be answered regarding care. The receptiveness of the more experienced RNs to newer RNs' questions, and the extent to which experienced RNs mentored and went beyond to assist the new graduate would influence new graduate decisions about asking for help. From the stacking study, 8 different decisions about what to do with activities on the list were identified. 4 decisions related to where to move an activity in or off the list and included defer, shed, reorder, or complete. The remaining 4 decisions related to preparation for better management and control of an immediate or future activity. These 4 decisions included recruit, cluster, be proactive, and reduce performance criteria, or do less than the guideline, procedure policy, or usual care calls for. The stacking decision to defer an activity relates to those purpose decisions that are based on an RN's decision to perform an activity at a time dependent on another event. For example, when an RN decides to defer teaching a patient until a significant other or family member arrives who needs to be educated as well. What makes this decision a difficult one in the context of actual work is that the required event is often unpredictable in terms of accurate timing, and or when the required event occurs, the RN may be preoccupied with some other unexpected care activity with another patient. To shed an activity from the stack was observed and reported to occur when there was a lack of time or resources to complete the task. These bumpable tasks included activities like cleaning up the environment, quality face time with patients, and tearing down IVs for the benefit of the next shift. Experienced RNs seem to make these decisions very easily and with confidence, using their clinical expertise and workflow management judgment to guide their reasoning about the consequences in relation to patient safety. Newer RN graduates were hesitant to offer information about what might not get done, more often asserting that they did not leave before completing their assignment. The choice to shed an activity might also be the result of a trade-off decision where conflicting goals competed for the RN's time and attention. This is an area that highlighted the differences between newer RNs and experienced RNs in the management of the stacking process. The reorganization and prioritization of the activities for the experienced nurse was very dynamic, reflecting flexibility and constant change in response to patient clinical conditions, as well as the workflow patterns and the needs of the unit. In contrast, the stacking process of the new graduate reflected more of the linear and routine approach to thinking characterized by Benner and colleagues' work on levels of nursing practice. The reorder decision was identified for those decisions required when some usually unplanned activity needed immediate attention and interrupted or precluded what had been planned. Examples of activities that led to reordering of the stack included unexpected admissions, tests, procedures or emergencies, physician or other healthcare provider needing assistance, or an upset patient family situation. To complete an activity is a decision in the stacking process and was clearly, for experienced and newer graduate RNs, one of the most satisfying decisions about activities in the stack. Completing activities looked like finishing 9 a.m. medication administration or completing the admission assessment of a new patient. The satisfaction aspect of completing activities is reasonable to expect given that much of RN work, especially for the more experienced RN, is surrounded by unpredictability. Yet there are endless opportunities to provide more care based on patient needs if time and resources were limitless. The experienced RN sees more of these opportunities, as well as the subtle signs of patient responses that trigger automatic nurse interventions that rescue patients and also prevent cascading of events that might result in losing control over the unit workflow and management. To recruit other people or resources for management of care is one of 4 stacking decisions that relate to preparation for better management and control of an immediate or future activity. The decision to recruit others as part of the stacking process was also identified as important work of the more experienced RN. Recruiting looked like asking for help from other team members, offering help to other team members knowing that their return of favor may be needed, teaming up to accomplish work safely, efficiently, as when ICU nursing staff respond immediately as a group to a new admission or code situation until resolved, and enlisting family members. The recruiting was clearly a decision and strategy for providing safe and quality care and necessary for efficiency. Enlisting others and assisting with care provided more time for other patients and care situations, and often provided better care and outcomes. Pediatric RNs demonstrated the importance of including parents as part of the care of children for building trust and often for gaining cooperation of the patient's participation in care. Detailed and sequential observation transcripts of individual experienced RNs during actual work situations clearly demonstrated the decision to cluster care delivery activities for efficiency. RNs with experience were observed to cluster, for example, by scheduling all care activities in one trip to the patient's room. Some RNs had developed strict routines before they left a patient room that involved the same checks in the same order. The checks involved not only equipment, arrangement of the room, and asking the patient or family if they needed anything. The checks for some RNs involved an assessment of the patient appearance. Experienced RNs manage patient care through carefully timed clustering of care. Students and new graduates tend to approach work in terms of individual tasks, for example, medication time, bath time, dressing time, and so on, until they gain confidence in the flexibility around multiple activities. While efficiency was given as one reason for clustering, an ICU nurse offered that if she performs the same routine every time she leaves a patient's room, she knows that any subsequent and even subtle change in the patient's condition or appearance can be measured against the very last time she was in the room. To her, it was a matter of providing safe and quality care. The benefits of this clustering and use of routine multiple checks result in less travel time, possibilities for more dedicated time with other patients or helping and recruiting other care providers, and some sense of control over management of the workflow by reducing the unpredictable. How can we better teach students the benefits of thinking in terms of clustered time with patients, rather than completion of individual tasks, both for safer care as well as efficiency? The ability to be proactive and perform tasks ahead of time to save time and or prevent tasks from getting out of control is another major discriminator of experienced RNs versus students or newer graduates. Examples of this decision relate to events such as anticipating the discharge of a patient so that activities related to discharging a patient are not left to be done quickly later in the shift. Staying on top of medicating patients for pain, knowing post-surgical or post-procedural patterns of patients' response. Anticipating and following through on patient-family requests to build trusting relationships that will help them cope, as well as make care delivery easier later on when time pressures prevent meeting some requests. Experienced RNs demonstrate an ability to see the day from very few bits of information and then plan their approach to organizing their work accordingly. They combine patient diagnoses, latest trend and status, plan procedures and tests for the day with who is working that particular day, and can then envision how they proceed and how they expect it will go. This vision enables them to be proactive and then to avoid what could occur and lead to events that compromise workload management of their assignment. How do we introduce students to proactive approaches to planning their day? The last stacking decision used to manage workflow and revealed through observations and interviews with RNs was to reduce performance criteria. This decision might look like one of the following examples. For example, modifying aspects of assessment to assessing only those systems relevant for this patient, given their diagnosis, despite the unit routine for a head-to-toe assessment at this time of the shift. Providing less face time with patients and families that is usually helpful to assess coping, satisfaction with care, and or questions they have not been able to ask. Reducing patient teaching time by reviewing materials without in-depth assessment of patient-family learning or demonstration of content. Given the unpredictability and time pressures surrounding multiple goals in nursing care delivery, trade-off decisions about what to do next might not always result in completely shedding an activity, but may lead to changes in the time allotted, the quality, or the depth of what an RN decides to do. For experienced RNs, making these decisions are done with safety and quality in mind. For example, if I am rushed and have multiple competing activities to be done now, what can I do now and still achieve safe patient outcomes? RNs delivering care in our current and complex health environments are in this position in terms of decision making on a daily basis. What can we do to prepare students for how to manage situations where this level of critical decision making is needed? Consistent with Benner and colleagues' research and literature about different care based on levels of experience, findings from the stacking study revealed differences in management of workflow based on experience level as discussed earlier. Major differences were found between newer nurses and those with more experience in numbers of activities in the list, the approach to managing the list, reactive to proactive, the movement of an activity from one level to another, and the inclusion of activities related to building or repairing relationships. In summary, nursing work is more than application of clinical knowledge content and procedural skills. Nursing work also involves decisions about the management of workflow that supports safe and quality clinical care delivery. Patient safety and quality depend on critical decisions about the prioritization, organization, and delivery of nursing care in complex environments.